Hello, everyone. I will be working on investigating the interplay between polycystic ovary syndrome, infertility, endometrial cancer, and their shared risk factors. The overall objectives of this study are to first explore the etiologic relationships between gynecological disorders and their risk factors, and then to develop an explanatory model for endometrial cancer with plausible causal mechanisms, which can inform targeted interventions. This study will address several women's health issues, most importantly endometrial cancer, which is the most common gynecological malignancy in the developed world. And in order to design effective presentation strategies to combat the increasing prevalence of these disorders, we must gain a better understanding of their root causes so we know where it would be ideal to intervene. I will be using a graphical model to illustrate the links between various disorders and factors of interest. In this graph, edges without a direction imply associations, and the arrows, on the other hand, will indicate causal relationships that I identified in my preliminary literature searches. So here I have Picos and infertility, which are both considered risk factors for endometrial cancer, and in the literature, Picos is also labeled as a leading cause for infertility. These disorders share many risk factors, such as obesity and diabetes. However, there's little known about the underlying causal mechanisms between all of these factors. The leading hypothesis for endometrial cancer is currently the unopposed estrogen hypothesis. This states that a hormonal imbalance leading to unopposed estrogen, either due to high levels of estrogen or reduced levels of progesterone, may be causing endometrial cancer. And while this can explain most of the associations among the disorders and risk factors, there is still many questions left to be answered. For example, what comes first? For obesity, diabetes, or Picos, we still do not understand the sequence of events. And how do the risk factors of these disorders interact with one another and with the environment to influence overall risk for endometrial cancer? Lastly, there are alternate pathways that may be leading to endometrial cancer independently from estrogen, and if so, what might those be? For example, obesity is also seen to be linked to estrogen, which could be causing the elevated risk for endometrial cancer. But it may be possible that a pathway exists with obesity and another factor, for example, adipokines, that can lead to endometrial cancer. Furthermore, there may be other environmental factors that might be influencing things like genetics to cause endometrial cancer. And there are many, many more risk factors and protective factors for endometrial cancer. I have just chosen a select few to show here. As you can imagine, this network will get even more complex as I add more factors. Typically, when determining causation, we use randomization, but in this case, that just isn't feasible. Instead, I will conduct an observational study to investigate the causal relationships among these disorders and their risk factors. But when using observational data to find causal relationships, I have to acknowledge that my findings are more susceptible to bias and confounders than if I use, say, a randomized controlled trial. However, with advancements in technology, I'm able to combine big data sources, which are now abundant, with epidemiological frameworks designed for causal inference from observational data. This study I will conduct in two phases. First, I will generate a hypothesized causal network, and I'm taking a multi-pronged approach to do this. In the beginning, I will conduct a literature review to discover all the variables of interest and use the existing evidence to hypothesize the network. But in parallel, I will start with observational data and use causal discovery methods and machine learning algorithms to infer a causal graph from that data. And in the second phase, I will compare and evaluate the two hypothesized networks using methods such as sensitivity analyses and Bradford-Hill's epidemiological criteria. We'll be using two data sets for this study. The first is the SWAN study. This is a longitudinal study, and the data is collected at 17 time points from almost 3,300 participants. The second is a CANPATH cohort. This is a cohort of healthy Canadians from which we expect will have over 150,000 eligible participants. Our eligible participants will be all female participants that are at risk from endometrial cancer, so all women with an intact uterus, essentially. To conclude, I will basically be just using a combination of traditional epidemiological approaches and novel causal inference methods to infer a causal graph for endometrial cancer. And I will do some evaluations of my hypothesized graphs, and future research can further evaluate them for accuracy. Thank you for listening.
Hi, everyone. I'm Lauren Tindale, and I'm going to be talking about a clinical ovarian cancer histotype classifier using gene expression data. So ovarian cancer is a series of distinct diseases typically identified by their histopathological appearance as either high-grade serous, low-grade serous, endometrioid, clear cell, or mucinous carcinomas. And these histotypes differ in their etiologies, molecular profiles, and clinical outcomes. So it's very important to correctly classify these histotypes in a patient's tumor. However, histotype classification by pathologists does not always agree. Among general pathologists, the inter-observer agreement using Cohen's kappa coefficient is between 0.54 and 0.67, which is not particularly good. However, in trained gynepathologists supported by immunohistochemistry, this increases to 0.89, which is a good level of agreement. So what we are trying to do is develop a classifier for ovarian histotypes based on differential gene expression profiles from different classes of tumors. And for this, we're using the nanostring encounter platform, which measures mRNA abundances. So what a potential workflow would look like is a patient would come in with a new ovarian tumor, and we would then quantify their gene expression of the tumor. This data could then be fed into an ovarian histotype classifier that would separate it into the 5 major histotypes. And this would also integrate very well with another classifier, Protype, which was developed by Aline Talhouk and Mike Anglesio, among many other people, which would then classify the high-grade serous histotype into its 4 further subtypes. So the methods we're using to develop this classifier is based on the data from 3 different code sets. And code sets is just nanostring speak for a set of reagents and probes. So we'll be dividing this data into a training, confirmation, and validation set, and training these models with the 72 genes that are common between the 3 code sets. And this Venn diagram here just shows the overlap of genes between those 3 code sets. And we'll be trying different algorithms as well as different ways to account for class imbalance. And high-grade serous does account for about 70% of ovarian tumors, so accounting for this class imbalance is important. And then I'm going to show you some results from a sensitivity analysis where we compare training on the entire training set with just code set 1 or code set 2, where each code set contains more genes that have potential predictive value, but there's less samples in those code sets overall. And the results presented are based on internal validation from 500 bootstrap samples. So some very preliminary data from earlier this week. We're showing the training set here with the overall accuracy. And along the x-axis, we have 5 different algorithms that we have tried. And in the different colors here, we have different subsampling methods. And of note, the pink dots here show that there's no subsampling done. And in the SMOTE subsampling, we've tried to correct for the class imbalance by synthetically upsampling the minority classes, as well as downsampling the majority class, high-grade serous, so that you get a more even level of distribution between the classes. And what we can see is that the random forest algorithm with the SMOTE subsampling does seem to have the best accuracy. That same training set, looking at kappa and F1 score, again, random forest and SMOTE appear to be performing the best. And of particular note, the kappa score is 0.83, which is really approaching that 0.89 that we see from expert gynepathologists. And looking at it on a per class basis, most histotypes are performing fairly well in this classifier. However, there are a couple histotypes like low-grade serous here that are not doing quite as well. So we're going to be looking at those more closely to see if we can improve the performance in these particular classes. And finally, I'll show you the results from the sensitivity analysis, where we compared training the entire set in green here with just training on the genes in code set 1 or code set 2. And what we can see is that the training set does appear to be doing better than code set 1 or code set 2, suggesting that the 72 genes that are contained in the training set do have a good predictive value for histotype. Separated by histotype here, we see relatively the same trend that the training set is doing better than the other two code sets. However, if we look at clear cell here, it appears that code set 2 is more predictive than the training set. So potentially there's some genes in code set 2 that have a good predictive value for clear cell in particular. So we'll be looking more into those. So as I mentioned, this is very preliminary. So our next step would be to optimize these genes used in the classifier by rank ordering them into the most important genes, removing the least important ones one at a time, and then reevaluating that performance. And then once we're happy with that classifier, we'll be confirming and validating that final classifier in those subsets of the data that we held behind. And finally, I'd just like to thank everybody who's worked on this project. There are many, many people listed here. And of particular note, I'd like to mention my supervisor, Aline Talhouk, Derek Chu, who is the statistical power behind this entire project, and Mike Anglesio. Thank you very much.
Hi, everyone. Thank you for coming to listen to me and my team talk. Let me just check that you could see my screen.
Yeah, you're good.
All right. So today I want to talk to you about clinical prediction models in gynecology. Specifically, I want to explain the role that clinical predictive models play in precision medicine and motivate some specific application to gynecological oncology. So I'm going to focus on an application in risk assessment, screening, and prevention in endometrial cancer. I do sort of want to, I guess you just saw the talk about Lauren Tindale. We're not going to talk about detailed diagnosis as another application, but that you just heard from Lauren. And then I'm going to talk also today about a prognostic application in endometrial cancer. And finally, I do want to promote an upcoming talk by one of the students that I co-supervise with Mike, Evan Karen, who's going to be talking about therapeutic response in ovarian cancer. So I just kind of want to highlight that there are some along the spectrum here, the continuum of care, a lot of applications. But I will focus on two, which are the risk assessment and the prognosis in endometrial cancer. So this work comes from our reconsideration of a one-size-fits-all paradigm in cancer care, which has evolved from our understanding that cancer is a heterogeneous disease. And there's lots of research evidence today from trials, observational studies, and knowledge that's obtained from routine clinical care that have generated these volumes of data, which are now we're able to analyze using some really advanced machine learning tools and algorithms, which we can now use to sort of synthesize this information to improve our knowledge base and help tailor care. And at the same time, I think medicine today is experiencing a bit of a paradigm shift in how we approach care. So from a disease-focused to a patient-oriented approach to research and care. And all of this, integrating all of this information, we have this emergence of this P4 medicine, which is predictive, preventative, participatory, and personalized. And if you've ever heard of these terms, they're really starting to be very popular and are often like buzzwords and maybe not very clear what they mean. I'm going to focus on precision medicine today. Because I think that the other ones are a little bit more specific, and this is a little bit more general. So here we start by thinking that everyone is different in their genetic makeup and their environmental exposures. And as a result, the trajectory of the disease that they may have will differ. And so what precision medicine does is that it aims to use all the information available to provide the right treatment to the right patient at the right time. And the idea of clinical prediction models and the role of these models I see that as part of a translational research umbrella, where we're using tools, or we're proposing tools that bring analytics insights to the clinic, to the bedside. And so therefore, all of the knowledge base that we derive from our data that's generated from clinical trials and observational studies, we use that to propose these tools that will help us guide decision making. And clinical prediction models can really vary a lot in complexity. So they could go from something very simple, like an if-then else prediction rules, to statistical models that are a little bit more involved, like linear regression or logistic regression, to something that's a bit more machine learning based, with like forests and trees and ensembles of methods, to something that's like a deep neural network and artificial intelligence based. And so these things are really varied in complexity. So I'm not going to talk a lot today about the different prediction models that one can use or how to evaluate them. I think I will do I will promote an upcoming course that I'm designing that does that. And I would point anyone who's interested to the tripod reporting criterion, where they talk about how to report these studies that involve prediction models with these, particularly with statistical and machine learning, as well as there's one now in development, the tripod AI, which will basically extend all of this to artificial intelligence. And how these clinical models are used in practice really differs. So this is an example of a decision tree where a patient comes in and you're basically test various things, and then you could follow the tree algorithm towards what to do. Other approaches are other tools that could be used are like graphical tools, where again, you're basically depending on the category where the patient fits in. You either have a green, blue, or red, and those have different interpretations. Maybe some of you have seen nomograms, and these are also other tools that are used. And at the end of the day, which tool you use really depends on, who the target of who is going to be using these clinical prediction models. Is it geared towards the patient? Is it geared towards the healthcare provider? What setting will they be in? What tools would they have at their disposal to make these predictions? Here's an example of a web-based one where you enter someone's age and different levels of different markers, and then you obtain a prediction. Here's an iPhone app in Gynecological Oncology, which I recently was made aware of. And it basically gives the probability of a lymph node metastases based on several risk factors. And those are the sort of implementations of clinical prediction models that we see today in practice. So when should someone develop a clinical prediction model? And this is a very nice, Martin Van Smeeden is an epidemiologist statistician who has, makes these nice flow charts. Some of them are, tongue-in-cheek, a bit jokingly, but then this one I think is quite good, is that first of all, the most important question is, do you need to make a prediction? If no, then you should stop, don't develop one. And if yes, who are you targeting with that prediction? Is it going to be, are you trying to select specific patients with some characteristic? Are you trying, what are you trying to do to who is this targeted? And once you have a group that you're trying to select, you could continue, otherwise stop. And then you ask yourself, is there data on such patients? And if not, you should stop or collect more data. Is an existing model available? And I think this is here funny, because he says this like, if the answer is no, check again, because often what happens is that many people independently develop prediction models, and that what we end up having is a bunch of, like, it literally litters the literature, because then we don't know, and then we don't know which one is good, which one isn't. They don't end up getting used. We're not building upon one another. And each time when we're starting over from scratch, we're having to use up all of our resources to gain power, to have for the statistical power of the initial model, whereas adding or removing something or changing the model requires less power. And I think that it's more efficient way of tweaking existing models rather than starting over. And so that's something that's very important to not do. Is there a large enough data set? And again, here by talking about data sets, we're not necessarily talking about number of patients, but we're talking about number of events. So in other words, if you have a very large data set, but you only observe 500 events, your effective sample size is 500. It is not 1 million. And so it is very important to know, to make sure that you're sufficiently powered to do the analysis, that you've observed enough events to be able to create these models. And then how common are the predictors? Are the predictors, is your data, does it have some unique features that only you can derive? Or is this something that other people can derive in their own settings? So I think those are things that are often important to ask before. And of course, you know, he provides some advice here about avoiding dichotomization, penalizing when possible. So you want the most simple model as much as possible. Make sure that you're rigorously internally and externally validating, calibrating the model, and thinking hard about missing data and how, whether or not you're omitting them, you're imputing them, and how they're being imputed, and following the tripod guidelines whenever publishing. And these are all very, very good. This is very good advice. So my lab has done research along the journey so we work in cancer, and we've done research around risk assessment of identifying in the population who is susceptible of getting cancer. You know, there's a lot of research around screening and making sure that you're able to detect disease early, diagnosis, so typing, prognosis, so basically assessing how aggressive the disease is and the likelihood of recurrence, and predicting who will respond to specific therapy, and of course, long-term monitoring of recurrence and outcome. So today's talk, I'm going to focus on risk assessment and screening detection, and also on prognosis and to some extent prediction. But you know, obviously there's a lot of examples of these clinical prediction models along this continuum. So starting with risk assessment and screening in endometrial cancer. So as most of you may know, endometrial cancer is the most common gynecological cancer in the developed world. So around 70,000 new cases in North America. It's also really the second most common cancer in women who have an intact uterus. So if you're not at risk of endometrial cancer if you have a hysterectomy or if you don't have a uterus. So this is, but if you do, it's the second most common cancer after lung. The incidence and mortality is increasing annually, and it is expected in BC that in about 10 years, we're going to have a doubling of mortality and an increase in incidence of up to 50%. So if it's diagnosed at an early stage when the cancer is still confined to the uterus, endometrial cancer is curable and has excellent survival chance. So what are the early signs of endometrial cancer? In 90% of the cases, endometrial cancer patients who have endometrial cancer will present with abnormal uterine bleeding. And abnormal uterine bleeding is defined as, you know, it's by its intensity, by its frequency. If it's any postmenopausal bleeding is considered abnormal. But however, this is a very common, basically abnormal bleeding accounts for 20% of visits to gynecologist's office, and basically impacts 1 in 4 women of reproductive age. And so it's also not very specific, because of all the women that have this abnormal uterine bleeding, only 3 to 10% will have a cancer or cancer-associated diagnosis. So the gold standard for diagnosing based on abnormal uterine bleeding is to undergo endometrial biopsy, which is a fairly invasive procedure, but that could be done in the gynecologist's office. And, you know, abnormal uterine bleeding, I mean, people are saying, okay, maybe we could identify patterns that are associated with cancer. But, you know, unfortunately, that's very difficult because what is abnormal is very different to everyone, because everyone's normal is very different. And so it becomes a challenge. And also, one thing that we know from the literature is that many women, over 50%, even when they experience something that they think is, or they worry might be abnormal, will do nothing about it. And because many of these abnormal bleeding result in non-malignant conditions, this is often not studied. It's not of particular interest. It's understudied and it's downplayed clinically. So we don't actually know what causes abnormal uterine bleeding a lot of the times, for sure. We also know that there are disparities, particularly racial and socio-demographic disparities in endometrial cancer. For example, Black women are more likely to be diagnosed at advanced stages of the disease. They are less likely to receive standard of care, and also they're twice as likely to die as white women from their endometrial cancer. We know that abnormal uterine bleeding is also documented less often in Black women, even after accounting for physiological differences in bleeding symptoms. So some of the reason for that has been attributed to like a gap in socioeconomic factors, lack of response from clinicians, lack of symptoms awareness, and just even plain health literacy. And so that is something that's unfortunate, but it exists. Now, just thinking back of how does endometrial cancer arise, so the majority of endometrial cancer has been known to arise progressively from endometrial hyperplasia. So, and again, I think this is not all endometrial cancer. The vast majority of the ones that we call endometrioid cancers will arise from this precursor endometrial hyperplasia. And the idea here is that the endometrium is a hormonal sensitive organ, and as there is an imbalance that may be caused by unopposed exposure to estrogen, the endometrium will start proliferating and acquiring these mutations that don't resolve with menstrual cycle, particularly if a woman, say, is postmenopausal and is not bleeding. And so as these mutations as the person starts acquiring these mutations, the clones will start forming and then eventually end up with a cancer diagnosis. So there has been, what's really interesting is that this disease specifically provides opportunities for early diagnosis or screening. And so the idea is because these molecular or these genomic alterations happen before the appearance of symptoms, maybe if we can identify a population that we could screen for these mutations in, then perhaps we could identify a cancer as early as possible, so that we could basically have this early diagnosis, the cancer is confined to the uterus, treatment by hysterectomy, and cure. But now the question is with the screening approaches. So as I mentioned before, there's the gold standard is endometrial biopsy, and there has been other minimally invasive approaches such as the Pap test, but which is not very accurate, only 45% accurate in detecting endometrial cancer. Another method collects cell-free DNA from uterine lavage, which has good sensitivity, but it's still quite an involved procedure that requires clinical resources. But recently, two PIs from OVCARE, who are part of the Gynecological Cancer Initiative, Dr. Anna Tinker and Dr. Michael Inglesio, have come up with have tested a minimally invasive tool that collects vaginal fluid from tampon, self-collection of tampons. And then basically from that fluid, once it's analyzed and sequenced, 68 of the 80 mutations were detected, and there was only one that was missed. And so this technology might be something that could be beneficial or could be promising in detecting as a minimally invasive strategy to detect endometrial cancer. But the idea is perhaps, you don't want to do this with everyone, and you don't want to unnecessarily alarm every woman. So maybe it would be feasible to look at here at women who are at high risk, right, to do the screening approach. And so here, maybe those are the women that are approaching menopause, women with Lynch syndrome. So taking a look at what are some of the risk factors for endometrial cancer could be of interest. So for example, here, these are some of the risk factors that have been shown in the literature to be associated with endometrial cancer. So when a woman starts her menstrual cycle, when late menopause is a factor, parity, so how many children they have, whether they have polycystic ovarian syndrome, exposure to exogenous androgen, so maybe if they took tamoxifen for treatment of their breast cancer, if they take oral contraceptive, even I would say exposure to like xenoestrogens and things that they're maybe getting from the environment as well. Metabolic factors could be also risk factors such as diabetes, high blood pressure, gaining weight, BMI. Lifestyle factors, eating a high glycemic diet, not exercising, smoking. Smoking is actually positively, so it's actually protective of endometrial cancer, but I think that, again, these are not causal. This could be like a confounder. There may be a confounder out there. Coffee is the same. And there are other hereditary factors like Lynch syndrome, and we know that in Lynch patients, they're 10 times more likely to get endometrial cancer. And often we do recommend screening currently for Lynch patients with annual endometrial biopsies. So some of the questions that we are interested in answering is, can we identify this population at high risk so that we're able to do targeted screening? And then if we can identify patterns of abnormal bleeding that are associated with cancer and that can account for individuals' variations, that would be really very interesting. And also, can we use these less invasive tools to monitor high-risk patients for early detection, and how effective these things are? So I'm going to focus on the first question today. So identification of high-risk population. So I'm going to start by talking about test characteristics. So when you're doing a screening test, you often look for sensitivity, specificity, positive predictive value, negative predictive value, and I'll define those briefly to remind everyone. So sensitivity is correctly identifying those that have the disease. Specificity is correctly identifying those that don't have the disease. Positive predictive value is the proportion of those with a positive test who actually have a disease. So in other words, if positive predictive value is low, I have a high false positive rate. Negative predictive value, those are the proportion of those with a negative test who have the disease. And again, if this is low, then I have a high miss rate. So here, I want to just highlight why it's important to go to identify high-risk population. So high-risk population will have a higher prevalence of disease, and higher prevalence of disease will impact the positive predictive value greatly. So here's an example. So this is three tests that have sensitivity of 90%, 70%, 50%, and as we look at positive predictive value here on the y-axis as a function of specificity on the x-axis. And in the first panel here, we're looking at a prevalence of 32% versus B prevalence of 9% versus a very low prevalence of 2.5%. And you could see that in order to have a good enough positive predictive value, your sensitivity and specificity have to be really, really high. Whereas if you have a high prevalence, the predictive value does not have, the sensitivity and specificity don't have to be so high in order to have a good positive predictive value. And that will make the positive predictive value, will make it such that the screening test is more feasible. So this hopefully motivates why we need to identify high-risk populations. So there has been two models that combine all these risk factors that I've discussed earlier about endometrial cancer to come up with an absolute risk of a woman without any symptoms getting endometrial cancer in the next 5 years. And so these were two models. One was by Pfeiffer et al. In 2013. So they did a large prospective population-based US study of non-Hispanic white women. And there is another one that was done in Europe in 2016, and again, using a large data set of women. So their sample size was around 200,000 participants. And again, those are roughly around the same period. So the first model was validated in an independent cohort. And there's C statistics. So the C statistic is what we use to determine how good the model is. And we want something to be very close to 1. If it's close to 0.5, it's pretty much flipping a coin. And if it's close to 1, it's perfect prediction. And here the C statistic was 0.68. And so that's not very good. And for sure, it's not good enough to make, to basically manage clinical management of these women. For the Husing model was not externally validated, but it was internally validated only, and it had a C statistic, was a bit better, 0.77. And so it has moderately good predictive ability. So more recently, in November of 2020, a group from Yale published a paper in the Frontiers of Artificial Intelligence. And what they did is they reanalyzed the Pfeiffer data using machine learning. And they showed that they were able to have an AUC of 0.96. So AUC is very similar in its interpretation to the C statistics. And so it's very comparable. So we could compare them. So this shows a significant improvement over what was done by Pfeiffer, essentially. And what they also did, which was interesting, is they compared their model to what they asked, I think, 16 different physicians to assess the risk of these patients based on their characteristics. And the model was 2.5 times better at identifying women at above average risk compared to physicians. And there was a twofold reduction in false positive rates. So there is a role here for machine learning or clinical predictive models to basically select or to identify this high risk group of patients. So we recently obtained funding from CIHR to validate these two risk models in the Canadian population. And we are going we basically applied for and obtained access to the CanPath data. So that's the Canadian Partnership for Tomorrow. It's from 10 different provinces in Canada. And then it's we basically identified 150,000 patients at risk, and approximately 500 have had an endometrial cancer diagnosis. So this data, the patients, when they're recruited, they did not have cancer, and then they monitored them. And as they monitor them prospectively, they look at outcomes, and 500 of those patients have already had endometrial cancer. And so what we're going to do is we're going to validate the models that have been published previously to see how well they perform. But also we're going to try to see whether or not we can integrate additional data from the Canadian, from CanPath, including integrating environmental exposure from CANU, which is an environmental data set. So just briefly, I'll discuss the predictors that each of these models used. And again, they're very similar, mostly parity, BMI, menopausal status, hormone therapy use, oral contraceptive use, interactions between these different things, smoking status, etc. So just going back to the questions that are asked in the algorithm is this a right application for a clinical prediction model? So is prediction needed? And I hope I convinced you that yes. And then this is population. So basically these are people at high risk, but who do not necessarily have symptoms. And there is such data on such patients? Yes, but I have to say here that we are limited by the data that was collected by these studies. So if there are additional factors that could be predictive, which we have not collected, then we will not be able to study them, obviously. There are existing models which we will validate and improve on. And I think our data set is large enough to identify, it's large enough, and we have a bunch of tools that we have at our disposal to deal with this imbalance, and to basically adjust the cohort so that we have enough events as a function of the total to allow us to predict who is at high risk. So before I finish here, there are also other opportunities. And this was from a study, this algorithm is from a study that was published recently in Cancer Prevention in 2020. And so the idea is, can we use this sort of AI technology and machine learning technology to further refine how we manage patients? So for example, maybe starting at age 40, women can start reporting or assessing their vaginal bleeding, reporting on menopause symptoms, obesity scores, etc. If they're at high risk, the app recommends self-collection of data. This could be lipokines, insulin sensitivity, genetics, tampons, etc. If at low risk, you have to reassess every year, but to really use this as an opportunity to provide education, diet, exercise, advice, hormone therapy, intervention if needed, metformin, aspirin, etc. for the low risk patient. And for the high risk, then you ask them to see the healthcare provider who would do the regular sort of workup for biopsy, and to make sure that we get the diagnosis done in time. And again, I think the shift here is moving more towards using digital technology, perhaps, to sort of help usher in these women, and so that you could alleviate the impact that it could have on the healthcare system as a whole, but also provide everyone with opportunities to self-monitor and increase awareness to the risk factors. So moving along, so now we'll discuss prognosis and prediction. So now someone has already endometrial cancer. So as I mentioned, in nearly all the cases, patients will undergo hysterectomy to remove their uterus. And when the cancer is confined to the uterus, hysterectomy is often curative. But there are about 15 to 20% will still experience a recurrence and die from their disease. So we cannot predict patient risk today at the time of diagnosis. So we don't know when they're diagnosed how aggressive their cancer is, who will recur. So generally, after diagnosis, what happens is that based on their histotype and their grade from their endometrial biopsy and a preoperative clinical assessment, patient will be referred to a tertiary center so that they could meet with a gynecological oncologist. But about 20% of cases with metastases will be missed on clinical assessment. We know that. And we know that MRI imaging, which is the best way to assess metastases before surgery, is not always done, and it can be very costly. We also know that histopathology performed on a biopsy does not always agree with the one assigned on hysterectomy. So we know that the Cohen's-Kappa, an agreement between biopsy and hysterectomy, is 0.44 for histotype and 0.55 for grade. And that's very low. And that's even when done by a gynae subspecialist pathologist. And so we could expect about 40% of diagnoses to change between biopsy and hysterectomy. So as a result, many women are going to be assigned low risk when they're in fact high risk, and vice versa. And so even that has resulted in some recommending that everyone should just get referred to gynae oncologist at this point, so that we don't miss anyone. But that may be a little bit too much for a cancer that has very good survival outcomes. So in 2013, there was an important study done by the Cancer Genome Atlas that mapped comprehensively the endometrial cancer genome. And by looking at that data, they identified 4 molecular subgroups with distinct prognostic signature. But the methods that were used by the TCGA were just too expensive and impractical for clinical use. So our group and several others have developed more pragmatic algorithms that can recapitulate the prognostic group from the Cancer Genome Atlas, but without using the full genomic analysis that they did. So we've developed confirmed and validated this decision tree that basically when a patient comes in, we look, so we've refined it as well recently. So now the final algorithm that we have, when a new patient comes in with endometrial cancer, we look at whether or not they have a polypathogenic mutation. And if they do, we call those polymutated. If they do, we also test their MMR. And if they have an MMR deficiency, but no polymutation, we call those an MMRD or MMR deficient. And then if they have MMR intact and no pathogenic mutation, we test for P53 abnormality. And if they are abnormal, then they're called abnormal. And then we have this catch-all, no specific mutation group. And in our studies, and this has been validated over and over, we know that this molecular classification is very prognostic, and it remains prognostic even after adjusting for other risk factors such as age, BMI, histology, grade, stage, LVSI, nodes, also all of these prognostic factors in endometrial cancer. And even when we compare to risk stratification methods, which are used to direct care, so here's one, for example, from the European Society of Medical Oncologists. So we look at the C index, and again, this is going back to the C index, a measure of discrimination where 0.5 is chance and 1 is perfect. We compare different models with between one another based on overall survival, disease-specific survival, and progression-free survival. And we see that all the models that include PROMIS are very similar to the models that have ESMO. The only advantage here is that we actually can get PROMIS. It has almost a perfect agreement between when assessed on biopsy versus when assessed on hysterectomy. And the model that's proposed by ESMO could only be evaluated at the time of surgery. So this gives us the ability to know from the time of diagnosis to be able to predict this risk of recurrence and to be able to stratify high risk and low risk patients based on information that are available at the time of surgery. So a preoperative risk stratification model for recurrence will take into account everything that we know at the time of diagnosis and use molecular information as well as clinical characteristics to consistently triage patients at high or low risk. And that could have important implications to the patients, right? So a patient that's called low risk for recurrence will be assumed to have an early stage disease that's confined to the uterus, can be treated in their community, can be considered for fertility or ovarian sparing surgery. They may not require full staging. They do not need any adjuvant therapy, perhaps beyond surgery. And for patients that we would call high risk, would be presumed to have aggressive disease, would need to be treated by a gynecologic oncologist. They would need to be offered radiation and chemotherapy, and then cannot be or shouldn't be offered fertility sparing options. But here's a depiction of some of the risk factors that we are trying to do. So basically, that we're trying to use to model. So here we're looking for PROMIS feature, ages diagnosis, body mass index, comorbidity, histopathology, hematological markers such as CA125, availability of imaging, clinical assessment of extent of disease. We use all of that, we feed that into our model to obtain risk. But the risk here is going to be, this model is going to be based on clinical outcome, which is recurrence and death from disease. And we only have observational data in this case. And so there is something that mediates between the risk and between, so this risk is going to be present, But between risk and clinical outcome, we're going to have all of these different treatments that would have been assigned. Again, there's a bit of confounding. It's a mediating variable that's going to influence clinical outcome. And that mediating variable is going to be informed by risk in many ways, because obviously the surgeons and the gynecologists that are making these calls to decide to choose between these different treatments, they're doing so based on some of these risk factors. And so it provides a very interesting modeling paradigm to account for all of those, to assess risk while accounting for the impact of the treatment that was selected on clinical outcome. And so that's going to be, we just completed, we also obtained the CIHR funds to do this project. We've just recently completed the assessment of all of these risk factors on our cohort. We're almost done, maybe we have 500 more. And we have a pretty sizable cohort in BC. We have close to 3,000 patients that have molecular subtype assigned, and we were able to fill out basically fill in all of this information, and we're sort of ready now to start modeling. And of note, there are several other models that have been proposed preoperatively, but none of them use molecular subtype. So this is where the novelty of whatever we're doing is going to come in. So going back to our little flowchart here, do we need a clinical prediction model in this case? I think yes, we definitely know that having this information earlier will help guide patients' treatment decisions. So of whom and for whom, I would say this would be more geared towards clinicians and gynecologists. Is there data on such patients? Again, yes, but we only have the data that we've collected or the data that we have available. There may be additional data that is needed, but that we don't have, but that's a limitation, I guess, always. Are there existing models? Yes, but none of them use molecular subtype. And is there a large enough data set? I think if anyone in the world could do this type of analysis, it would be us, because we have the largest molecularly subtyped series of endometrial cancer. And are there common predictors? And the answer is yes. Most of the predictors that we think are that impact decision-making are collected, and are available and easy to collect. So for sure, yes, in this case. And with that, I thank you all for listening, and I'm happy to take questions.